Welcome everyone.
Sir, 1 minute. I give you confirm call.
Welcome all of you to the ESPRA webinar series. Uh, you all will agree with me that COVID-19 pandemic has been an eye-opener for all of us in the healthcare industry. We are fortunate enough to be able to communicate with you all through this online platform. Friends, dyspepsia is a very common problem and notoriously difficult to treat. We have one of the experts in the field of gastroenterology today to enlighten us regarding dyspepsia and impact of COVID-19 on dyspepsia and its management. I introduce you Dr. Sushant Kumar Sethi, who is a leading expert in the field of gastroenterology and hepatology in Odisha. He was previously at AIIMS Delhi and Apollo Hospital Delhi, and currently he is at Apollo Hospital Bhubaneswar. Dr. Sushant Kumar Sethi has a number of publications in reputed journals to his name and has given a number of talks on the various burning topics in gastroenterology all across the country in various forums. Thank you very much, sir, to join us today for this webinar. We have Dr. Rajat Khandelwal also as a moderator who will moderate the session and the question answer round. Friends, you can see the question box on the right side of your screen where you can ask question during the session, which will be answered by our respected speaker at the end of the session. Dr. Sushant Kumar Sethi, I hand over the session to you. Thank you very much.
Okay. Good evening, everyone. So I welcome you all for this webinar, which is rampant nowadays during COVID era. So the topic today, I'll be covering COVID-19 pandemic and non-ulcer dyspepsia. As we all know, so COVID was first reported in Wuhan, China in December 2019, and the COVID term comes from coronavirus, which is due to SARS-CoV-2, severe acute respiratory syndrome coronavirus 2. And earlier, this coronavirus particularly has caused MERS like Middle East respiratory syndrome and another epidemics in China. But this one is quite catastrophic and devastating, which first reported from Wuhan, China in December 2019. It was declared as a public health emergency on 30th January 2020, classified as a pandemic on 11th March 2020, and till date, to the tune of 6 million cases globally has been reported to be affected from COVID pandemic. And the mortality till date is staggeringly high, which includes close to 3.65 lakhs people. And the fatality rate varies from USA 5.9% to the world average like 6.15% to a staggeringly high mortality rate in Italy, which is to the tune of 14.3%, which is attributed by the higher age at the rate of infections. The average age of individual in Italy who are affected is 62, in contrast to Germany, and which is 52. In India also the average age is low. So that probably explains this case fatality rate, of course. And we all know with multiple comorbidity, the fatality rate that increases. So that is the reason probably in Germany, because of maybe testing facilities, because of early lockdown or early measure, the fatality rate is low in contrast to Italy, which is contributed by average age of infection, which is higher, and multiple comorbidity and other issues. However, whatever may be the cause and impact, it has caused tremendous psychosocial and economic impact as of today. Not only this is the global scenario, and when we talk of India, and we are facing a challenging situation in India as well. First is reported on January 30th, 2020, and doubling time currently is 13 to 15 days, and we are expecting more cases because of movement from or transportation from people from one place to another place, whether they are workers, laborers, or once with the train, the other modality of transports will be open, then we are expecting higher people will be affected. But by now, we realize one thing, that we have to live with COVID, and the COVID infection is persisting, is going to persist with us in months, within next few months, even if not years, and the infection rate will be higher, but the mortality rate will be sort of under control. In India, the mortality rate or fatality rate to the tune of 2.87%, which is rather encouraging in contrast to other populations in the world. So that was regarding COVID, and what regarding dyspepsia. So dyspepsia is bad digestion or difficulty digestion, sometimes you may say, and many people they describe dyspepsia as epigastric discomfort, early satiety, that means feeling full after taking a little amount of food, bloating, heartburn, nausea, acidity taste, upset of stomach, and belching. So various people they manifest dyspepsia as different types of presentations. The data from Indian subcontinent regarding dyspepsia is scarce. We are doing some studies which are, will be out soon, but it will take few years maybe. Last data, whatever we have as per Rome 2 criteria, which has been revived, it says as high as 25% of populations they have dyspepsia in general populations. That's the prevalence, and incidence is 1 to 6% annually. 3/4 of patients with dyspepsia walking into OPD have no identifiable cause. If we are not identifying any cause of dyspepsia, we term it as idiopathic, functional, or non-ulcer dyspepsia. And 1/4 of patients usually have some underlying pathology, which is organic cause of dyspepsia, which includes gastroesophageal reflux disease, peptic ulcer disease, and gastroparesis. So peptic ulcer disease, gastroesophageal reflux disease, gastroparesis are different. And if you are not getting any cause, identifiable cause in endoscopy, then only you will talk either it's a case of non-ulcer dyspepsia, functional dyspepsia, or idiopathic dyspepsia, which they present with various symptoms. But less than 0.5% of this dyspepsia presentation could be due to GI malignancy. As like in India, we are seeing more cases of CS stomach, so we have to consider carcinoma stomach as a cause of dyspepsia, because that could be catastrophic if you diagnose late. Most of the times, the CS stomach patients, those who are once they present to the doctor, they might not be in a position to be operable. So let's say advanced stage of malignancy. Sometimes we might be dealing with. Coming to the causes of dyspepsia, 78% usually, as we discussed, this is non-ulcer, we do not get any cause. And rest of the percentage, we might find esophagitis, peptic ulcer disease, other causes, which includes GI malignancy. So common causes includes functional medications, peptic ulcer disease, gastroesophageal reflux disease, hiatus hernia, gastroparesis, and uncommon causes includes upper GI malignancy. There are some overlap between pure functional dyspepsia and others such as GERD and gastroparesis. That is the reason earlier heartburn, retrosternal burn especially, we are also considered as case of dyspepsia. So dyspepsia, as you know, basically we are talking of the symptoms of stomach and duodenum. If we are getting retrosternal burning, so that might be because of esophagus. That is the reason we are separating the esophageal symptoms from the stomach or duodenal symptoms. Even then, they share some type of common presentations, like heartburn could be due to acid peptic problem like gastric peptic dyspepsia, and could be due to GERD also. So sometimes they share, and functional we may 50 to 70%, and organic might be 30 to 40%, and there is an overlap where they both are sharing with each other. And this is the thing: esophagitis, peptic ulcer disease, gastric cancer, and organic. This is the percentage what we get. So how COVID-19 is associated with this non-ulcer dyspepsia? So COVID-19, in the COVID-19 especially, most of the periods we have for last 2 months or so, we have been under lockdown. So during lockdown, what happens? The psychosocial factors, they play a role. As pathological, we will discuss the pathophysiology, we will be knowing that psychological or psychosocial factors, they are important factors to aggravate or stimulate or initiate dyspepsia, non-ulcer dyspepsia, which includes also sedentary lifestyle. Because of lockdown, people are having sedentary lifestyles, no work. Dietary habit, there are a lot of change of dietary habits because of this lockdown period. Maybe some people, they are taking, the junk foods, and the frequency of meals also increased. The amount also increased because people didn't have much things to do. So the more focus was shifted on diet. So dietary habit also contributes as the cause of non-ulcer dyspepsia. Apart from those, financial or career-related stress, uncertainty they also take a toll when we are discussing the cause of dyspepsia. So this figure implies various causes or associations of dyspepsia along with these things. One important factor is stress, as we discussed. Stress of loss of job, financial stress, the stress of disease, stress of other persons in the family. So various type of stress, they precipitates or aggravates dyspepsia. How? We'll tell. Second is alcohol. Alcohol, though it is not directly associated with dyspepsia, but it has been seen that in some cases it aggravates if somebody is there having dyspeptic symptoms, or else some pathology in the stomach, alcohol aggravates that. Apart from that, getting alcohol or not getting alcohol is a stress regarding these eras. At least we faced some people, those who are alcoholic liver disease, and our last 2 months they actually got better because they didn't get alcohol. In contrast, some people in search of alcohol, they also got stressed. So it could be a cause of dyspepsia on a lighter note. Another things are chocolates, the junk foods like cola, the chips, and all these things. They are associated with the study suggested that they are also associated with the dyspepsia or aggravation of non-ulcer dyspepsia. So they could have been caused more dyspepsia during this lockdown period. Smoking or nicotine, it aggravates dyspepsia. It is also associated with dyspepsia. Same with excessive caffeine. Excessive use of caffeine or coffee also associated with dyspepsia. So these are the foodstuffs and psychological factor, etc. They are related to COVID-19 and dyspepsia, what we are discussing today. So coming to the Rome for criteria for diagnosing functional dyspepsia. So functional dyspepsia actually is because of is presented in one or more of the following. One is a bothersome postprandial fullness, that means heaviness after taking a food. Bothersome early satiation, that means feeling full after taking a little amount of food. Many times in a week, the patient is not able to complete his meal, and because he feels full after taking a little amount of food. That is what known as early satiation. Bothersome epigastric pain and bothersome epigastric burning. So epigastric pain, epigastric burning, postprandial fullness, and early satiety, they are the common manifestations, and those symptoms usually present more than few occasions in a week for 2 to 3 months to stamp dyspepsia. And no evidence of structural disease, including upper GI endoscopy, that is likely to explain the symptoms. Then only we will call it functional dyspepsia. If we are getting some findings in the endoscopy like some duodenal ulcer or gastric ulcers, then that cannot be called as dyspepsia only, because there's peptic ulcerations. So these are the same things. Postprandial distress syndrome and epigastric pain syndrome are two different kind of symptoms. They are characterized in case of functional dyspepsia. Postprandial distress syndrome is bothersome postprandial fullness occurring after ordinary sized meal at least several times per week, and or early satiation that prevents finishing a regular meal at least several times per week. Supportive criteria: upper abdominal bloating, postprandial nausea, or excessive belching can be present. Epigastric pain syndrome may coexist. In epigastric pain syndrome, pain or burning localized to the epigastrium of at least moderate severity at least once per week, and the pain is intermittent and not generalized or localized to the abdominal or chest regions. If it is localized to the abdominal region or chest regions, like suppose epigastric regions, right upper quadrant, and the increasing gradually, remaining in a plateau and declining gradually, it could be biliary pain. So this could be gallbladder stone. If you are getting gallbladder stone, these are biliary coli. If there is some problems in the chest due to pneumonia or something like that, so it is localized, then you have to see some problem in the chest wall or pneumonia or something like that. That might be causing abdominal pain also. So you have to actually exclude that before stamping epigastric pain syndrome. That is the reason, that is what they are telling. Not relieved by defecation or passage of flatus. If it is relieved by defecation or passage of flatus, that is probably could be irritable bowel syndrome. So irritable bowel syndrome also is a functional GI disorder. So, but which involves basically large bowel. But in contrast, functional dyspepsia, it involves stomachs and duodenum. So that is the reasons. If not it is relieved by defecation or passage of flatus, you can stamp irritable bowel syndrome, not non-ulcer dyspepsia, not epigastric pain syndrome. Not fulfilling criteria of gallbladder and sphincteropodite disorders. Supportive criteria includes the pain may be of burning quality but without retrosternal component. Retrosternal component, if you are talking, it could be gastroesophageal reflux disease. There could be non-cardiac chest pain and retrosternal burning might be there. It could be non-gastroesophageal reflux disease. So nowadays, we are separating gastroesophageal reflux disease with dyspepsia. So the esophageal pathology or disease symptoms of esophagus they are separated from stomach and duodenum symptoms. So the pain may be of burning quality but without a retrosternal component. The pain is commonly induced or relieved by ingestion of a meal but may occur while fasting. Postprandial distress syndrome may coexist. You can see over here, epigastric pain syndrome may coexist with postprandial distress syndrome, and postprandial distress syndrome may coexist with epigastric pain syndrome. That means there is no watertight compartment to distinguish between this is postprandial distress syndrome and epigastric pain syndrome. In fact, they might be coexisting, and one person may not exactly describe with one syndrome particularly to you. Actually, the patient usually have combination of or amalgamation of all the symptoms of postprandial distress syndrome and epigastric pain syndrome when we are seeing a case of dyspepsia. So the differential diagnosis includes peptic ulcer disease, gastroesophageal reflux disease, gastroparesis, irritable bowel syndrome, malabsorption, medications-induced GI symptoms, GI malignancy, particularly pancreatic malignancy, gastric malignancy, etc., etc. These are the differential diagnoses we must exclude while we are dealing with the case of functional dyspepsia. The causes include upper GI tract peptic ulcer disease, acute gastritis. Acute gastritis is a thing what we are thinking. Acute gastritis is a thing what we are talking. It can be described by various people in different manner. The clinicians sometimes they describe acute gastritis if patient is having recurrent vomiting. The endoscopist might describe acute gastritis if he is seeing some injury inside the stomach, and pathologist might describe gastritis once they are getting some evidence of inflammations in the tissue specimen. And clinicians sometimes they describe all of these. So acute gastritis, gallstones, esophageal spasm, non-ulcer dyspepsia, irritable bowel syndrome, pancreatic cancer, chronic pancreatitis, hepatitis metastasis, and some systemic diseases, and drugs which can commonly cause dyspepsia includes NSAIDs, corticosteroids, iron and potassium supplements, digoxin, etc., etc. And it is contributed or precipitated by psychological factors like anxiety, depressions, neurogenicity, neuroticity, and also, of course, by alcohol also. Sometimes it precipitates and aggravates. This slide shows basically these are the presentations of dyspepsia, the weight loss, hematemesis, etc., etc. When these are the symptoms, presenting symptoms when you are doing endoscopy for all those indications, weight loss, hematemesis, anorexia, etc., etc. It has been seen if the patient is having more than 55-year-old, the chance of getting a organic pathology is more likely. In contrast, the patient is having less than 55-year-old. You can see this. The significant pathology we usually find if the patient is in elderly individual at least more than 55 years of age. So the significance of this is when you are somebody complaining with dyspepsia and presenting to you, whether you advise or don't advise endoscopy, where the shear stomach or gastric carcinoma is not very common, then it basically depends upon the age group of individual. If a 25-year or 30-year-old patient presents with dyspepsia, you may not advise endoscopy unless there is no alarm symptoms. But in contrast, if a 55-year-old, more than 55-year-old patient presents with dyspepsia, you should advise an endoscopy to rule out shear stomach or gastric malignancy. So this is the GRD and dyspepsia. It's found in 25 to 20% of patients with dyspepsia. They have same features. Typically also complaints of heartburn and regurgitations. This is GRD. And as I said, the features might be, associated with each other, and they might be sharing one or more symptoms with each other. So pathophysiology remains like the gastric motility and compliance, and the gastric motility and compliance. This fundus part is sometimes not compliant with the food whatever the patient is taking. Visceral hypersensitivity of the stomach in this particular individual, which is visceral hypersensitivity, is determined by some neurochemicals secreted from the brain and gut hormones. Altered gut microbiome. Nowadays, we are contemplating gut microbiota in most of the diseases. We come to know whatever the gut microbiota they manifest, or the alterations of this particular set of microbiome, they changes the milieu or micro environment of the stomach, and they might precipitate certain things. So that is one important mechanism. Psychosocial dysfunctions, as we discussed, whether it's anxiety, some depression, some neurosis, they might precipitate the things. Helicobacter pylori infections, the most important thing is one Helicobacter pylori infections, which is associated with the dyspepsia, and that is the major thing we target when we are treating non-ulcer dyspepsia and also duodenal inflammation. So they are the pathophysiological factors which contributes for non-ulcer dyspepsia. What happens when you take a normal meal and there occurs spondylic accommodation or receptive relaxations? This is the part of the stomach, cardia, body, and fundus, and this is the antrum. Actually, this area behaves differently with this area. The function of this area is different. This area serves as the reservoir. Once the patient is taking food or a normal individual is taking food, what happens? This area accommodates food. Once it is accommodated or full, then only it propels the food into the antrum. In antrum, there occurs churning or process of trituration. The churning and trituration process makes these particles very smaller so that they will be negotiable or easily passable through the pylorus. Then the duodenal load, the load is over the duodenum. That normally these other hormones from pancreas and other things they come into place. Then normal digestion process occurs. So this is the normal phenomenon. What happens in functional dyspepsia? There occurs impaired fundic accommodations. This fundus cannot accommodate more food with a redistribution of food into antrum so that it releases the food to the antrum. Once the more food is there in the antrum, the patient feels heaviness. The patient feels bloating. And once the food is redistributed, patient feels early satiety, as if he had taken enough in the mid of the meal. Second, the duodenal load to the kind of food or fatty acid, whatever, also they contribute for the cause of dyspepsia. It has been seen that if you inject caspicin into the duodenum, caspicin which is a composition of chili, then it causes the abnormal motor complex or movement of this from the fundus to the antrum, so that there occurs dyspepsia. So the normal individual, this is what happens. The food accumulates in the fundus and it comes to the antrum appropriate time and it passes through the pylorus when they are small in size and everything goes smoothly. But in case of dyspepsia, there occurs impaired fundic accommodation with the redistribution of food into antrum. The hormones also their role play. Psychogenic factors they play a role. And because of all these, this dyspepsia occurs. The most important thing what we are seeing today is stress and behavioral factors. As I said, what we see earlier, there occurs neurochemical imbalance inside the brain, and lot of gut hormones they play a role and their role in digestion. Many times the clinicians we see the patients present is that one gas is coming and it is going to my head and sometimes it's going through my feet. And wherever I am pressing, I am, having some burping of some kind of air is coming. 4 years, 5 years down the line, we are thinking what rubbish the patient is talking about. But today, what we come to know for last 3 years, there exists a gut-brain axis. The gut-brain axis, the lot of hormones, they are interrelated from the command of the brain, the neurochemicals, those who are having modulation of the digestive system and presentation and behavior. Probably those type of manifestations are the modulation of the brain because of dyspepsia symptoms. So nowadays, gradually we are getting more and more data, they are coming out. Actually, those symptoms whose patients are telling, they are true. So it is not just psychotic. So earlier we used to stamp what rubbish you are taking. Now that gradually the mystery is being unfolded. So the stress, the behavioral factors and other neurochemicals and the many hormones like CCK, substance P, motilin, gastrin, etc., they play a role in this abnormal motility, which finally causes decreased antral motility, impaired fundal relaxation, what I spoke regarding in the previous slide, and also that is contributed by Helicobacter infections. H. pylori infection also causes the damage to the mucosa, which causes the environment or which changes the milieu of the stomach to an alkaline environment and precipitates all those whatever pathological mechanism we are postulated. So in the bottom line, so patient is having dyspeptic symptoms. Once patient is having dyspeptic symptoms, these are the red flag signs which needs upper GI endoscopy. What are those? They are age greater than 55 with new onset dyspepsia, dysphagia, that means difficulty in swallowing, unintentional weight loss, that is what is important, GI bleeding, persistent vomiting, iron deficiency anemia, which is not explained, palpable epigastric mass or lymphadenopathy, abnormal barium meal. Nowadays, we are not doing barium meal, but in case you are doing something abnormality in barium meal, that also needs an endoscopy before we start non-onset dyspepsia and going for treat and test strategy. So these are the features. If they are there, then you should go for testing. So how to make a diagnosis? The symptom-based diagnosis criteria and an evaluation to exclude other causes of dyspepsia, as we discussed. History, physical examination, laboratory studies, endoscopic evaluation to exclude organic or structural diseases. Sometimes, if patient is having dyspeptic symptoms but not having any other symptoms or no other alarm feature, what if you do endoscopy? As I said, many cases, and in our setup in India, so we rather prefer test and treat strategy. First we test, we do endoscopy, we rule out other things, we test for H. pylori therapy, then we will treat. Many times without symptoms, we will find this type of lesions. It could be depressed lesions in the antrum, which could be early gastric cancer. One should not miss that, especially when gastric cancer is prevalent. One should not miss that. When H. pylori is one of the important cause nowadays, we come to know of this gastric cancer. As such, 60 to 80% of gastric ulcers and 80 to 90% of duodenal ulcers, they are because of H. pylori, and majority of this dyspepsia are also caused by H. pylori, Helicobacter pylori. So this is one thing we must be careful about while we are doing endoscopy, or if endoscopy is needed, we must not miss this. Second, many times, even if with this patient may not be symptomatic, patient may present with dyspepsia symptoms only, or maybe sometimes the patient might be very much symptomatic, but you will not get anything in the endoscopy. That means no organic pathology may be found in the endoscopy. So this can happen. So you have to remember that. NSAID and dyspepsia, the risk factors of NSAID-induced ulcers, age more than 60 years, past history of peptic ulcers, past history of adverse events with NSAID, concomitant corticosteroid uses, high dose of multiple NSAID, and high-risk NSAID, which includes indomethacin, ketoprofen, and pyroxicam. So they all causes problem. NSAID for dyspepsia is a problem. Whether it is low risk or high risk. Low risk are celecoxib, idurcoxib, low and ibuprofen. That can have medium risk also, and diclofenac, ketoprofen, etc. They are actually precipitate aggravate and sometimes cause ulceration and bleeding in case of dyspepsia. And also they can cause dyspepsia also. So how to manage in a case of functional dyspepsia? So according to the ACG guideline in 2017, what we do if an adult dyspepsia presents, the patient presents with postprandial fullness, epigastric pain, epigastric burning, and early satiety. These are the 4 cardinal manifestations. Then if a patient is less than, these are basically uninvestigated dyspepsia, and these studies came from Canada and USA basically. So this age, etc., we consider 55, but they consider 60. So less than 60 years of age, if H. pylori infection is there, test and treat. H. pylori infections can be tested by either endoscopic method or non-endoscopic method. Right? H. pylori, I am going to tell you soon. The test can be done by endoscopic method or non-endoscopic method. Urease test or rod test. We can take biopsy. So RUT, biopsy, tissue PCR, and tissue culture, so they can be done by H. pylori. And apart from endoscopic, there are non-endoscopic modalities. Non-endoscopic modality includes serum or serology, IgG antibody test, stool antigen test, and urea breath test. So urea breath test, stool antigen test, and serology, IgG antibody, they are non-endoscopic, and those are endoscopic modality. Well, once it is positive, which can eradicate H. pylori, success, that is fine. Then negative, we can continue PPI for longer period, 4 to 8 weeks. and no response, we might add, tricyclic antidepressant or prokinetics. And if not, then we would consider psychotherapy or behavioral therapy or whatever. So more than 60, endoscopy, organic pathology, treat accordingly, normal, manage accordingly. So general advice or lifestyle advice: reduce weight, exercise, meditations. That goes side by side with all, advice what we talk as a clinicians. Stop smoking, all forms of tobacco, avoid alcohol, healthy diet with fiber, food, etc. Fruit, water, plenty of water. Those are things to be advised. Small frequent meals rather than heavy meals, because as I said because of impaired funding relaxation, most of the food load is on antrum and patient will be more symptomatic. Review medications like steroid, NSAIDs, etc. Consider anti-acids preparations like for GERD and peptic ulcer disease, PPI, and all the things, and other side effects also to be considered. Step-by-step management of functional dyspepsia. Fast test for H. pylori test. High prevalence in India, including reinfections. What happens in India? By second decade, by 20 years of age, most of us, 80% of us, we develop H. pylori. In contrast to USA or other developed countries. In USA or other developed countries, so they might be having H. pylori infections, which is not more than 20-30% during past decade or so. But later on, usually they eradicate. I mean, they get free of these infections. But India, in contrast, they are occur reinfections. By second decade, by 20 years, 80% of us, we get H. pylori infection. So our protocol is a different protocol in contrast to USA and other developed country, where they are not having much of CS stomach, not having much of peptic ulcer disease. But here, we see acid peptic disease, peptic ulcer disease, whether it is duodenal ulcer or gastric ulcer more. For an example, and also it varies from one population to another populations, one place to another place. India is a not a country; it is like a continent, because this the rice-eating Bengalis or Odias, we are different than wheat-eating Punjabis. And in my experience, what in Delhi we used to see 30 endoscopy, I was not used to see any ulcer. But here in Bhubaneswar, if I did 20 to 30 endoscopies, I see maybe 7 to 8 ulcers. So 20 to 30% we are having peptic ulcer disease in this area. So, and as I said, the Indian subcontinent, we people are different, and our approach to the H. pylori infections and our approach to endoscopy, our approach to dyspepsia is definitely different rather to the USA or other developed countries. So what we do, treatment of options in functional dyspepsia, H. pylori indication is positive. If there occur some symptoms and some more than 45-year-old individuals, otherwise patient is having symptoms and some confusion, we do endoscopy and we eradicate H. pylori after doing rapid urease test if it is positive. So no positive, no H. pylori documented positive, it should not be tested. Many times I see the clinicians or the physicians, they without documented H. pylori infections, they start anti-H. pylori therapy, which is not advocated actually. So H. pylori eradications relieve symptoms in functional dyspepsia patients. These are the many studies, they suggest H. pylori eradications, they actually lead to eradication of symptoms in patients. Various studies are there, these are the studies. So all these studies, they say the same thing. H. pylori is associated with the dyspepsia. That is first. Second, eradication of H. pylori, the dyspepsia symptoms, usually it goes in good percentage of cases. So H. pylori, as you know, is a gram-negative microaerophilic rod, and that in 2000, actually, the H. pylori, because of the H. pylori infection, they invented, the Marshall and Warren, they discovered that H. pylori infections was there, and they got Nobel Prize for that. From that, or since that period, our change or our concept of treating acid peptic disease, peptic ulcerations, and bleeding has changed. Earlier, if you remember 30 years back, 40 years back, people used to have surgery for duodenal ulcerations, bleeding, gastric ulcerations. Nowadays, hardly you see a patient which is undergoing surgery unless it is complicated by some malignancy, some perforation, etc., because of peptic ulcer disease. And basically, there, the credit goes to PPI and H. pylori infections. So once we have PPI and once we came to know H. pylori infection, which can cause dyspepsia, peptic ulcer, and gastric cancers, nowadays we are in a better position to treat with H. pylori to all other things so that we avoid major complications. But there is a caveat. Nowadays, the resistance to H. pylori is very high. In Indian scenario, resistance to clarithromycin is to the tune of 30 to 40%. I repeat, the Indian scenario, the resistance to clarithromycin is to the tune of 30 to 40%. What we in India we do, clarithromycin, amoxicillin, and PPI, along with this we combine. But what we the recommendation, the latest recommendations, what we are recommending for first line therapy as far as pylori infection is concerned, bismuth salt, along with PPI, standard PPI BD, tetracycline, and metronidazole. These are adopted because of high resistance to clarithromycin. And we have found that few studies, the bismuth is actually very good for eradicating H. pylori when it is combined with all those. And this duration is for the 14 days. So concomitant therapy, strong recommendations, it is moderate quality. If bismuth salt is not available, earlier it was not available, recently only it is available. What we used to give, clarithromycin, amoxicillin, metronidazole, along with PPI. Some have clarithromycin, amoxicillin, and PPI. Some had clarithromycin, metronidazole with PPI. So like that. But resistance to clarithromycin and amoxicillin is also high. So that is the reason we are considering bismuth and other therapy. So treatment options in functional dyspepsia include H. pylori eradication, if positive, then PPI therapy. How long the PPI therapy? Again, that's a dilemma, a debate. So in developed world, they prescribe 8 weeks, 6 to 8 weeks of PPI therapy. After that, if not responding, then they switch on to other modality, searching for other diagnosis. But in India, what we used to see, the people usually need PPI therapy for months together. Once they are off PPI, they are again symptomatic, so that you have to put them with PPI again, PPI back again. PPI are also nowadays, they are coming with a lot of side effects, lot of papers. They talk about what are those PPI they are coming, but by and large, they are safe. And second, if patient needs PPI, then only give. So without that, without monitoring, you should not continue PPI for indefinite period. That is important. So evidence for use of PPI in functional dyspepsia, there's a 15 RCTs. These are the number of patients, and all of the patients, all of the studies showed there is a good data for PPIs in the support of PPI to treat dyspepsia. So treatment options includes H. pylori eradication if positive, then PPI therapy, and if they fail or patient is not responding, you can add tricyclic antidepressant therapy. When you combine with that tricyclic, compare between tricyclic antidepressant therapy versus SSRIs, actually TCAs are far more better than SSRIs. SSRIs are usually not helpful in case of treating dyspepsia, but TCAs are. So evidence of TCA used in functional dyspepsia, these are the evidence. So these number of RCTs, they had been supportive in use of TCA, and in SSRI, unfortunately, so they were not very fruitful. And there is a subgroup who responds better to TCA. They are basically those people they are having some sort of gastroparesis, some nausea, and they are actually better. They respond better to the TCAs. With delayed gastric emptying. So patients with delayed gastric emptying, they respond better to the TCAs. So this is the same thing. So, but antidepressants, they have also their own side effects: sedations, dry mouth, constipation, orthostatic symptoms, etc., etc., etc. So you have to monitor and take cautions before using that. And also some TCAs, along with some prokinetics, so they cause, like I'm coming to the prokinetics, they cause cardiac conduction severity also. So prokinetic, in case of delayed gastric emptying, as I told, many of our patients, they also present with heaviness, bloating, and delayed gastric emptying. So the symptoms are actually they combine all the symptoms of delayed gastric emptying, epigastric pain, along with all the things. In there, the patients, they might need prokinetic therapy. So after H. pylori eradications, if you test and treat, then you treat for PPI therapy if patients are not responding, or else you are getting any symptoms of delayed gastric emptying like nausea or some sort of symptoms, then you should add prokinetics before TCA. This is our approach. My approach, and this is the approach of all of us. Usually we adopt that. You can add prokinetics. So prokinetics are available like domperidone, metoclopramide, ecotiamide, cinetepride. So these are the prokinetics available. In USA and Canada, there are very less number of prokinetics, and they are also US FDA, not approved by US FDA. Whatever little amount are there, they might be like cisapride. They are associated with cardiac conduction defect. So we are not using those. And what we saw, few of the prokinetics, they are safe, but still then you have to monitor. like metoclopramide, they pass the blood-brain barrier and cause extrapyramidal symptoms. Like livosulbiride, they also cause some either excessive prolactin secretions, hyperprolactinemia, and all these things. In case of some tremor, extrapyramidal symptoms. Domperidone actually in cardiac defects, cardiac conduction defect in very little percent of cases, though we are not encountering that. And other PU are cinetepride, ecotiamide, not much studies are there, and whatever studies are there, so they are having less side effect. So you have to choose the prokinetics accordingly, and if patient is not responding to prokinetics, then you can think of adding TCA. So these are so suggest functional dyspepsia patients not responding to drug therapy should be offered psycho. If patient is not responding to everything, then you can actually refer the patient to the psychotherapy if you strongly feel that that elements needs to be addressed. But in contrast, in our country, India, in our state also, so what we see, so with 2 months or 8 weeks are not the time to for the patients to respond over here. So they might need at least 3 to 6 months of time. So, this is the algorithm. Functional dyspepsia patient, if H very negative, then PPI. Then in our practice, we add actually prokinetic. Then if not response, then TCA and consider psychotherapy. And in H indications, if it is positive, eradicate H pylori, as I discussed, either with bismuth and 3 other molecules, or else clarithromycin, amoxicillin, pantoprazole, which is readily available. We are giving if you are getting success, well and good, or else you continue PPI for longer periods. So you should refer the patient to the endoscopy if patient is either more than 55 or over with treatment-resistant dyspepsia, upper abdominal pain, raised platelet with any of the following: nausea, vomiting, weight loss, reflux, dyspepsia, etc. And these are the things or alarm symptoms. You must refer the patient to the endoscopy. In COVID era, these are the few guidelines for endoscopy procedures. Now we have categorized urgent, non-urgent, or semi-urgent endoscopies. So before doing endoscopy, do the basic rites. Try thoroughly if you can ask proof of travel tickets, etc., so that you should accommodate minimum number of cases with low risk, protect yourself. So those things we are stricter earlier. Gradually we are unlocking ourselves also. But if some of you are doing endoscopy, these are the tips: involve minimal staffs, no overlapping roles, adequate PPE, make sure N95 fits perfectly. For plain endoscopy, if you are doing endoscopy, and because endoscopy is an aerosol generating procedure, you must wear N95 masks and face shields at least, if not PPE. Many times practically with PPE, this is difficult to do some therapeutic procedures and all. But if you are suspecting strongly, then please use PPE and cover all surfaces in endoscopy room and thorough cleaning afterward. Consent can be verbal earlier if you are avoiding touching and all these things to the patients. And remember to take consent for possibility of contacting infections during the procedures. That also will help you. So these are these various PPEs people are used: low risk, intermediate risk, and high risk. So you have to protect yourself. Basically, avoid oral anesthetic spray. Consider procedural oxygen mask and endotracheal intubations of all the procedures if it is possible. And most important, if you are doing ICU cases and there is negative pressure isolations, if you are suspecting strongly COVID patients or COVID positive patients, then do in negative pressure rooms, especially in ICU, taking all the precautions. So, ladies and gentlemen, to sum up or to conclude my talk, what I would say: COVID-19 has an unforeseen global impact, including economical and psychosocial issues. Diseases such as functional dyspepsia and irritable bowel syndrome may play a stress and behavioral aspect have role in pathogenesis. Functional dyspepsia is common, but definitions are imperfect. As I told you, the postprandial epigastric syndrome, and epigastric pain syndrome, they might be correlating with another. One thing might be overlapping with another, so you have to see that. Address lifestyle, medications, and risk factors. Simple dyspepsia, empirical treatments. No alarm symptoms. Young patients, you can do empirical treatment with PPI. Otherwise, in our protocol, what we do, most of the patient test and treat H. pylori. If alarm symptoms there, for sure. If age is more, for sure. If in your family history of some CS stomach or something like that, then of course, for sure. And if the prevalence of H. pylori infection is high and CS stomach is high also, it's better to test and treat. But in a young individual, 20-25-year-old, or one or occasional symptoms, you may only treat with PPI. Red flag symptoms, urgent endoscopy or gastroenterologist PPI are better than placebo for functional dyspepsia. H2 blockers, they also play a role, but PPIs are much better than that. TCAs are showing benefit. Prokinetic if delayed gastric emptying is suspected, and psychological therapy to address the issue of neuroticity or anxiety, depression, etc. etc. Endoscopy is an aerosol generating procedure. Gastroenterologist teams are vulnerable to infections. Screen patients and stratify the procedures according to low, intermediate, and high risk. Nowadays, gradually, you should be opening off to accommodate more patients, but take a precaution and have a proper screening. Proper PP with proper technique is indispensable, and minimal staff negative pressure rooms should be used. So this is it about this COVID-19 and dyspepsia presentations. And now, any question, any comment, Dr. Rajat? Thank you so much.
Sir, Jai Jagannath sir, I was waiting not to interrupt you because sir, you gave so much good information. Sir, I'll be first of all pleased to inform you we have more than 300 registration for today's webinar. So your basic information regarding this functional dyspepsia and in the COVID-19 time has reached a lot of people. Also, sir, we have questions pouring in. So with your permission, I will start one by one, sir.
Yes, yes. Please.
Sir, also I would like to say, sir, that there are several general practitioners as well and across the country from Tamil Nadu, Gujarat, Maharashtra. I'm getting questions from everywhere. The team from Zydus who are supporting us, they're also putting up the questions that they're receiving from the general practitioners. So, sir, please bear and you can answer. Their question may be very basic level for you, but I think it will give them a lot of information.
Go ahead, yes.
Sir, are you, first of all, the question is, are you getting more patients with this dyspeptic symptoms during this COVID-19 time?
Yeah, so during COVID-19 times, actually, we are not consulting, so we got phone calls. Definitely teleconsultation, I got more of patients with teleconsultation with dyspeptic symptoms in this COVID-19. Yes.
Sir, there is a very pertinent question. Do pregnant patients complain more of dyspeptic symptoms, and what will be the therapy of choice in pregnant patients?
Yes, that's a very good question. Pregnancy is a condition which not only it causes dyspepsia, it precipitates dyspepsia, it precipitates reflux also because of diabetic uterus. Not only because of diabetic uterus only, pregnancy makes the whole environment by change of microenvironment inside the patient's body because of hormones, estrogen, progesterone, they come to role play. As I said, hormones play a major role in this also. So nowadays we know pregnancy in pregnancy dyspepsia precipitates, aggravates, or in a normal patient might be having dyspepsia. As a rule, on first 3 months, usually we do not give any medications, which is PPI or something like that in dyspepsia. But at the same time, we have to see the symptoms. With pregnant patient, but very much symptomatic, vomiting, which interferes her day-to-day life, then please go ahead with your PPI. So usually nothing will happen. Sometimes we can go ahead with H2 blocker also. If you are very skeptic, you can go ahead with H2 blocker. But many patients, usually they will get better with PPI. Otherwise, their day-to-day life will be hell and they will land up in more complications. Second trimester onwards, so comfortably we can give PPI and other things. We are not doing endoscopy in pregnancy, so no endoscopy in pregnancy, unless otherwise very serious like some open GI bleeding or something like that. In dyspepsia per se, no endoscopy in pregnancy, and we can treat them with H2 blockers, or we can treat them with PPI also. In first trimester, we'll prefer either H2 blockers. They're pretty safe in contrast to PPI. But in the second trimester onward, we give PPI. But at the same time, if patient is symptomatic, not responding, then you can give PPI in first trimester also.
Right. Sir, there is a question from Dr. Bhavya. She wants to know two-part question, sir. Whether irregular food habits are actually the cause of this functional dyspepsia, means the irregular relative of timing. And second, whether there is any long-term implication for these patients having functional dyspepsia. Are they at any risk for any problem?
Okay. So irregular food habit, definitely that is associated with dyspepsia. As we discussed, diet and lifestyle, they play a major role. So once your food habit is irregular, if you are taking more spicy food, more junk food, more fast food, and more caffeine, etc., so they can aggravate dyspepsia. And they aggravate dyspepsia by various methods, including the change of, these hormones, the change of gastric motility, whether and it has been seen earlier, as I said, that if you infuse this thing into duodenum, the duodenal dysmotility also occurs. They all prescribe dyspepsia. The long-term complication is same. The dyspepsia patients, if they are not treated, the same thing, they might lead into acid peptic disease, peptic ulcerations, and as we discussed, the far more serious complication like CS stomach. I'm not saying dyspepsia patient directly to go to CS stomach, because H. pylori infection is one of the cause of dyspepsia, and H. pylori infection is one of the cause of CS stomach also. So in that, if untreated, the patient might be having gastric ulcer and might be leading to CS stomach also. You have to keep that in mind.
Excellent. Sir, Dr. Reshma has sent a question. She wants to know, have you ever encountered your patients on PPIs, on long-term PPIs, any adverse effects, particular adverse effect that you have seen in your practice? And the second, she would like to know the duration that you would prescribe PPIs for.
Okay, that's a very good question actually. So PPI, we are using PPI for last 20 years or so, and I'm using also last 10-15 years or so. In my practice, I have definitively never encountered a case and any particular problem with PPI. But many times we saw increased creatinine because of acute kidney injury because of interstitial nephritis or whatever PPI we are known to cause in sometimes. It's very difficult to establish, yes, this particular kidney injury is due to PPI or not, but sometimes we had seen some increased creatinine level, and at that time we stop PPI. After 3 months, 4 months, we see then the creatinine might be normal, but we restart PPI also, then nothing happens. So I can say it's a bias, but that might be a problem. But apart from that, other things, other possible complications like PPI complications, if we discuss what complications we had thought of, because of PPI, we had thought of bacterial overgrowth syndrome. We had thought of magnesium, calcium, other homeostasis, the derangement in all those things. Where even if people have advocated the fracture or excessive, osteoporosis fracture because of PPI, people have correlated carcinoid tumors, and people have correlated acute interstitial nephritis and all other things. But none of these studies, whatever we found, they did not establish any adverse effect of PPI which is beyond reasonable doubt. At the same time, PPI is a huge market. Today, PPI is a billion dollars of market. Once in this market, we are having more pressures that we must judiciously use PPI. The second questions I will be answering. The bottom line is that if somebody is not needing PPI, they should not try PPI also. But whatever medications we are giving, that must be based, or the decision must be based on risk and benefit ratio. Like everywhere we take risk and benefit ratio. What is the risk? What is the benefit we are going to achieve? Somebody is a patient with GRD and acid peptic disease. Here, what do we see? At least I give treatment for 3 to 6 months. But many times I see, once they are off PPI, so they will be again symptomatic. Then once you are treating again, they will be asymptomatic. So you have to take a call till how long one individual needs and how long it can be given judiciously. At the same time, you should not tell tell them it is pretty safe, you just go on taking for indefinite period. So you have to tell them these are the problems, but you need that is the reason we are giving. So you have to check it after 2 months or 3 months or 6 months, whatever time is suitable to you. They must check you. You might do a serum creatinine level, and if not other things, just to rule out there is nothing wrong with PPI. So by and large, the PPI are safe, but yes, you have to take a caution.
Sir, I have a personal question, sir. Have you felt in your practice or during your study of the data or the literature any difference between the different PPIs that are available, sir?
No. So the answer is no. One answer. So various studies they have showed. Apart from all those studies, few studies showing this particular molecule causes arch in this pH, and this particular molecule has a rapid absorption, and this particular molecule is not good in along with clopidogrel, some interaction is there, and this particular molecule is good with clopidogrel. But by and large, whatever data till date we have, all PPIs are more or less similar.
Right, sir. Sir, Dr. Balram wants to know, sir, is endoscopy painful for the patient and does it require sedation?
Endoscopy definitely causes discomfort. And if 10 patients I do, 6 to 7 patients, they definitely tell discomfort. 1 or 2 patients, they may tell, no, I didn't feel anything. But definitely endoscopy is a procedure of discomfort. But sedation, yes, of course, it depends according to your practice, what you are doing. And if you have an anesthetist in handy and you can manage that, then it's better to do with the sedations. But it increases the cost. In our country, we have to see the cost also.
Right.
So that is the reasons what we usually do without sedation, with local anesthesia.
Right, sir. Sir, Dr. Rupam has posted a question. Sir, should stool occult blood be done routinely in patients presenting with dyspepsia?
No. Stool local blood, if you do stool local blood, if you feel something, some alarm pictures, then only you will do. Suppose dyspepsia along with low hemoglobin, for an example. If dyspepsia along with low hemoglobin, then you do the stool occult blood if patient is having some bleeding or not, occult bleeding. So otherwise, routinely in dyspepsia, you should not do. But in dyspepsia, if he is an elderly individual, more than 55 or even more than 45 in India, if we consider, then you should advise endoscopy. Stool occult blood will not give you any definitive thing. Only thing is that it will give a clue that patient might be losing blood from the GI tract, which at least you have to do 3 consecutive tests. If 3 consecutive tests that is positive, then you can only get one conclusion: patient might be losing blood through GI tract. That's it.
Sir, I have a few questions from Mumbai. I think they are all on the same theme, so I'm going to put it together, sir. They have asked, first of all, in your opinion, what would be the best medicine for dysfunctional dyspepsia? Would it be a PPI or would it be a combination? Second part would be, sir, could you treat it without medicines? Can you treat it naturally, and can it be treated only with lifestyle modification?
Okay, so answering your first question, so whether PPI only or prokaryotic only or combination. So as I said, most of the people, those who are presenting, they are actually presenting with mixed picture. So I am more comfortable with PPI in prokaryotic rather than treating with PPI, and after 2 months they will come and they will add prokaryotic. At the same time, I have to see younger individual, 20-year-old, otherwise not symptomatic, then I might not add PPI. Small child, 8 years, 10 years, I might not add prokaryotic, I'm sorry. So only with PPI I will manage. But if he's having some bloating sensation and I get some evidence of delayed gastric emptying, it's better I will do step down approach. That means I will first start with PPI and prokaryotic. After a month or so, then I will gradually reduce the prokaryotic and I will stop that. I will continue the PPI. Once patient is asymptomatic or otherwise, then I will stop PPI also. So usually I follow step down approach rather than step up approach. So that in most of the individuals, but in selected individuals, I treat only with PPI only. Second question, coming to second questions, only lifestyle modification and all these things. Lifestyle modifications and dietary habit, they go side by side. You have to remember, if patient is coming to you or presenting to you, by that time he is symptomatic, that means there is some changes in the body. In India, our patients, they do not go to the doctor at once. They will have past symptoms. They will have all sort of remedy which is available to their locality or whatever by searching Google and all these things, and they will present you later. If a patient is presenting with you, by that time you have to intervene. Only diet, only lifestyle will not solve the purpose. You have to intervene with PPI and prokaryotic. But diet, lifestyle modifications, all of the things like stop tobacco and stop taking excessive spicy food, do daily exercise, that goes side by side. So along with medications, that has to go. But without medications, that may or may not solve the purpose, I'm afraid.
Got it, sir. Sir, there's another very interesting question. Can chest pain be one of the symptoms? Among the symptoms that you described, do patients come to you and tell chest pain as one of the symptoms?
Yes. Again, same thing. So one non-cardiac chest pain, what we commonly see, most of the patients, the young patients, when they are presenting with chest pain, so it could be non-cardiac. But you have to see what are the types of presentations. If there is some discomfort along with sweating, if the pain goes to the jaw, pain goes to the left shoulder, that means that could be angina also. So you have to see what are the other comorbidity patient is having. The diabetic patients presenting with chest pain, then we have to see about that, whether slight clinical suspicion, then it's better to do an ECG and clear there is no cardiac problem, because it might so happen young patients might they are also coming with AMI. And as I said, as I used to say, the cardiac problems they will kill the patient. That will take the patient's life. But non-cardiac or acid-peptic problems, it will not. So at the same time, you should not rule out the cardiac possibility if you have slightest clinical suspicion, but treat with non-cardiac cause like dyspepsia or GID or whatever.
Right, sir. Sir, continuing in the same line, I have few questions that are asking whether ecosprin and aspirin in general, can they aggravate the symptoms of dyspepsia?
Yes, NSAID and aspirins, they usually aggravate. They are the notorious causes. If patient is having some cardiac problem, coronary disease, patient is having ecosprin, and presence with this, then usually they are having dyspepsia. But more often than not, in those cases, you will get a finding in the stomach in the form of erosions, ulcerations, or whatever. So not in typical functional dyspepsia where you will not get anything in the stomach. The mucosa will be looking normal, but patient will be symptomatic. But in contrast, if patient is taking aspirin or other NSAID, more often than not, you will get a finding or pathology in the endoscopy.
Somebody has asked a very practical question. I would love to get your opinion on this, sir. So they've asked, does the triple therapy that is prescribed for H. pylori eradication, can it aggravate the symptoms that the patient has presented?
Triple therapy, because H. pylori therapy, anti-H. pylori therapy, what we are giving, clarithromycin, amoxicillin, and all this, they are very poorly tolerable drugs. So 10 patients we are giving, H. pylori therapy, 6 or 7 out of them, they complain something or other. And that is first thing. And the second, we know the resistance of the clarithromycin to the clarithromycin is 30 to 40%, amoxicillin is also high, and metronidazole is also high, all these things. But unfortunately, we do not have any other molecule as of now. So bismuth came late, and along with combination of bismuth, we are thinking and we are hoping that will solve some degree of purpose. But we need to eradicate H. pylori because of two simple reasons. The patient should not land up in gastric cancer. So that is one most thing. So that is the reason. So for anti-H. pylori therapy, usually first few days, the patient will be more symptomatic. Symptoms are not due to, dyspepsia. Symptoms are due to the drugs. Those drugs, usually they are not very friendly drugs. But gradually, after 3 weeks or 1 month, usually it settles down.
Sir, one more question. I think it's from one of them who are afraid of this endoscopy procedure. They're asking, what are the diagnostic tools other than endoscopy?
Certainly we have, because we have to categorize or stratify the patients who are, because in India we are having our population is commonly we are having all these things. That is the reason we are doing endoscopy. But in developed country, USA, UK, Canada, or European countries, other European countries, endoscopy is not easily advisable. So you do not get to do endoscopy. So besides endoscopy, what are the tests what we are aiming for H. pylori testings? One is serology, IgG antibody, and stool antigen test, and carbon urea breath test. So these are the 3 tests, and urea breath test is a simple test, and they are sensitive also. Only problem with those tests in these are, so they are actually interfered with the PPI. Once you take PPI, so the result might be interfered, and we may not see the response. So after you treat them, after treating, if you are doing, so response may not be adequate. You cannot compare whether H. pylori is eradicated or not. So that produces a challenge. So otherwise, you can test H. pylori with all these methods.
Right. Sir, any comments on dysbiosis and dyspepsia, sir?
So dysbiosis is basically what we are talking fecal microbiota. We are contemplating everything this fecal microbiota. So they actually change the microenvironment of these like other things. In stomach particularly, because it is acidic environment, the other microbiotas they have a minimal role, but duodenum and below they might be having a role. So they might be contributing to this change of microenvironment of the stomach, which may predispose for the dyspepsia.
Sir, since you mentioned about the geographical variation, that is the wheat eating and the rice eating populations, there is one question. What factors do you think would be contributing to it? Is it only the food, or is it any other factors?
Yeah, that's a very difficult question, because actually the answer is that we do not know exactly what is happening. Multiple things are proposed. First and foremost is environment. because the treatment of water, because these are all waterborne infections, how the water gets treated over here, that is the first and foremost. Second, the dietary habit, the pattern of lifestyle. It has been seen that H. pylori infection is more associated where there is overcrowding, the sanitation is at stake, this more people they are sharing with one room, etc., that is more prone. So that is the reason the poorer states are bound to have those H. pylori. So in a developed state, but at this particular geographic area also they are having, like in our belt we have 4-5 states, we in like Andhra Pradesh, West Bengal, Chhattisgarh, Bihar, Odisha. So all of us we are having more of H. pylori infections. So it is attributed by one is this water supply. Second, the type of food. Third, tobacco. So tobacco chewers or use of tobaccos. Fourth, NSAID use, what they are using. And fifth, most important, it could be some genetic variations also. So that might be contributing. That is the reason we see celiac disease more in Punjab. We do not get more celiac disease in state of our state, Odisha, neighboring states. So that could be something like that. But exact answer is not known.
Right. Sir, few more questions, if you will permit, sir. Is functional dyspepsia the same as irritable bowel syndrome? Because irritable bowel syndrome can be, somebody has put this, that it can be managed but not cured. So is it the same true for functional dyspepsia also?
Yeah, that might be true. So these are the spectrum. Functional dyspepsia is same with lower reach irritable bowel syndrome. So what you need to do all those things in functional dyspepsia, that is functional dyspepsia or irritable bowel syndrome. Of course, functional dyspepsia has more definitive cause rather than this. Suppose somebody was taking some NSAID or some other things, once you will avoid and patient might improve. Somebody was having H. pylori infections, once you treat H. pylori, the patient might improve. More of the patients will improve. So that is not that troublesome like irritable bowel syndrome. Irritable bowel syndrome is a far more complex thing, so I'm not going to discuss that. But the bottom line is that you need to do the counseling. Once the patient comes to your chamber, the patient should go satisfied from your chamber. Otherwise, what it causes, it is difficult to treat, and they will go on doctor shopping, and that will cause enormous cost of healthcare cost, and it will end up in same problem. So that is how you should manage. You have to do for a counseling. You have to address these issues.
Sir, one last question, because this is COVID time, so I have to ask you the COVID related question. Two-part question, sir. Parts of the gut affected by coronavirus called COVID-19, and can the healthy gut help to fight coronavirus infection?
Yeah. So coronavirus infection, as we know, coronavirus can be found in esophageal epithelium, the cholangiocytes, the biliary tracts, etc., etc. So coronavirus, we are surprised, but COVID infection are the common presentations are not GI presentations. Diarrhea could be a presentation, maybe 5%, roughly 5% patients they present with diarrhea. Vomiting is non-specific, that is common, but coronavirus per se can be seen in esophageal epithelium, the GI tract epithelium, and cholangiocytes also. Another thing, the fecal contaminations, as we know, one study is from UN again. It showed the coronavirus usually that exists in the stool at least 2 to 3 weeks more than their respiratory epithelium. That means even if one patient is COVID negative by their RT-PCR from this throat swab, etc., then patient might be passing coronavirus in stool. That too, at least for 2 to 3 weeks, maybe for 4 to 5 weeks. So that led to think us whether fecal contamination is likely in case of coronavirus infection. If that is so, then what we would advise all the patients, those who are actually diagnosing for COVID-free, and they should be content, and they should not be allowed to use the common toilets and etc., where the chance of fecal contamination is likely. But fortunately, what we had seen, then even if fecal contamination, even if the coronavirus is excreted in the stool, the fecal contamination is less likely or unlikely. And second, they are not very symptomatic. When they are followed up for 3 weeks or 4 weeks, they are not very symptomatic. In contrast, when they are symptomatic in the respiratory epithelium. That means if you are getting them in respiratory epithelium, these like saliva, etc., that is, their patients are more symptomatic. In contrast, if they are excreting the virus fecal matter also, by stool also, they are not symptomatic. So they led to think us, then probably, so fecal contamination is less likely, but few other studies or furthermore studies are required to establish that. But coronavirus can affect the GI system. The common presentation is diarrhea, as far as GI system is concerned, and fecal contamination as of now it's not looking very promising, but other data are needed.
So the second part was, can a healthy gut help to fight coronavirus?
Yes. Like as the younger, though it's a respiratory infection, it basically depends on the immune system, your immunity, how you are fighting. So that is the reason what our advice in the healthy gut, you should take plenty of fruits, vegetables, fibers, plenty of water, no smoking, no tobacco, no alcohol, etc. Then if your GI, because digestive system is most important thing when we are combating with the infections, and that is the hormones also, they also come to they play a major role. So if your GI tract is fight and you are not having more of comorbidity, so for sure you can wipe the corona out.
Thank you so much, sir, for, as always, a masterly talk, sir, and a very clear and lucid explanation. This is I understand you must be getting a lot of patients. It must be tough for you to deal with patients who are coming recurrently with these complaints. Thank you so much, sir, for laying out a step-by-step pattern. Also, sir, I would like to thank our today's support from Zydus and all the members of the team, including Mr. Abhishek Anand, Kandarp, Punarbasu, and everybody, including the technical and support team. I think, and also for the extra time, some 10 minutes they've given, even though, sir, they've given us time, but still there are questions pouring in. I'll put some of them to you so that we can give it back to them by email.
Yeah, you can the answer.
Right.
Yes.
Thank you so much, and thank you for tuning in. I think we can wrap up, sir, with your permission.
Any other thing, Mr. Kadar?
जिग्नेश भाई लाइव बंद कर दो.
Thank you so much. Thank you.